Welcome to GIST Awareness Day. Woohoo, July 13th. We are going to be sharing GIST research updates. This is a time where GIST experts, patients, caregivers can come together to educate the public about this disease and advocate towards finding a cure. During this seminar, all participants should be muted during the presentation and feel free to unmute yourself to ask questions during our Q&A at the end. Please remember the information provided in this web seminar is not intended as a substitute for your physician's guidance and care. We would like to thank Genentech, Cogent, Decipher, Blueprint, IDRx, and Novartis for their educational grants for our webinar series. My name is Sarah Rothschild, and I'm the Executive Director of the LifeRaft Group, and I would like to introduce our presenters for today. Dr. John Glod obtained his MD and PhD from the University of Colorado in Denver and trained in pediatrics and pediatric oncology at Cincinnati Children's Hospital, Johns Hopkins Hospital, and the Pediatric Oncology Branch of the NCI. Dr. Glod currently serves as the Clinical Director of the Pediatric Oncology Branch in the Center for Cancer Research at the National Cancer Institute. Dr. Glod's research interests are focused on early-stage clinical trials for pediatric patients and rare pediatric solid tumors, including multiple endocrine neoplasia-related medullary thyroid cancer, sdh-deficient GIST, and tumors of the central nervous system. Dr. Ramesh Bulusu is the chairman of the Cambridge GIST Study Group and the UK clinical lead for the PAUSE GIST, which stands for Pediatric Adolescent Wild-Type Syndromic GIST. Dr. Bulusu is the founder chairman of the Cambridge GIST Study Group and the network lead for GIST in Cambridge. Dr. Bulusu is passionate about GIST and is currently heading a national focus group for PAUSE GIST. And in 2014, he established a national clinic in Cambridge for PAUSE GIST to facilitate research in this rare subgroup of GIST. And he did that in partnership with Jane Bressington from PAUSE GIST. Dr. Jason Sicklick is an internationally recognized surgical oncologist who specializes in treating GIST, abdominal retroperitoneal sarcomas, and liver tumors. He's the leader of the sarcoma disease team and co-leader of the structural and function genomics program at UC San Diego Health Moores Cancer Center. As professor of surgery and pharmacology at UC San Diego School of Medicine, Dr. Sicklick conducts basic translational clinical research to improve our understanding of GIST, as well as to enhance precision medicine approaches for treating metastatic cancers. His laboratory focuses on the molecular mechanisms of GIST development and drug resistance. So we have a very esteemed panel today, and I'm delighted to hand this off to Dr. Glod to begin.
So it's really my pleasure to be here today. GIST Awareness Day is always a lot of fun. It's always nice to get to see Dr. Sicklick and Dr. Bulusu and Sarah again and get to talk to people about things that are going on the National Cancer Institute and in the pediatric oncology branch. So what I'll try to do today in a very briefly is sort of recapitulate the history of succinate or sdh-deficient GIST research at the NCI and kind of give a brief overview of what's going on right now and what things we're excited about coming in the future. So I think probably the godfather, the grandfather of SDH GIST research at the NCI is Lee Hellman, and I don't know if you guys can see my pointer, but there's Lee kind of in the back of the group of one of the early GIST clinics, and Lee and many other investigators, some of whom are on this call, kind of recognize that there was a difference in GIST that was diagnosed in kids and adults. It became known that most adult GIST are driven by mutations in KIT, and that didn't seem to be the case in kids. And so the GIST clinic was established to try to figure out why that was and to try to develop better care for these patients and a better understanding of this disease. And I think we've evolved over that time. It's been really a great pleasure to meet so many people who are so smart and so dedicated to advancing therapy in this area. And I think one of the things that we're able to do now from the NCI is one, to provide some support for local providers with diagnosing and managing patients with sdh-deficient GIST. It's really been sort of gratifying to see the changes in phone calls that have occurred over the last decade, where people would call 10 years ago with a GIST patient that they couldn't identify a KIT mutation and were puzzled what to do with that. And now I think the majority of the referrals and calls that we get from outside providers, people really know of the existence of SDH-deficient GIST and really have some idea about the disease. But we can sometimes provide some help with the pathologic diagnosis. There's Dr. Miatinen up there in the corner. He's a pathologist who's really an outstanding GIST pathologist and can help with that. We can help patients identify trials that could be appropriate for them. And sometimes these trials are here at the NCI, but often they're at other places. But we can at least point people in the right direction. And then we have the ongoing pediatric and wild type GIST clinic. It's a yearly clinic. We usually bring about 6 to 12 patients to the NCI, in addition to a number of expert clinicians and scientists. And this has really been an exciting event and has been supported throughout by Life Raft. So Sarah's been to a number of them, and they're really a lot of fun getting to meet people and hear their stories. The person mainly involved in organizing and doing the logistics for the GIST clinic is BJ Thomas, and there's the NCI Pediatric GIST Clinic email there. If anyone is interested in participating, let us know. Or if you just have questions, please email and we can try to help you get those questions answered. There's a bunch of, in order to sort of advance the science in SDH-deficient GIST and develop trials that really make sense scientifically, we have and are currently trying to increase our understanding of the basic biology of SDH-deficient GIST. And there's a couple of different focuses of research, basic research on SDH-deficient GIST at the NCI. Paul Meltzer up here in the corner is really interested in the specific biology of SDH epimutant GIST, and this is a really interesting subgroup of SDH-deficient GIST that's driven by down regulation of expression of the SDHC gene, as opposed to a specific mutation in the gene. We also have a cadre of people that are looking at trying to identify ways to better follow the development of SDH deficient GIST in people. Can we develop a blood test or some biomarkers that can help us follow the disease, or even look for the development of GIST in people that have germline SDH mutations? And that's Dr. Shern and Taylor and Srinair, a very talented postback, and Dr. Sunby. There's a lot of work going on in the role of surgery and how other local therapies going to be applied to SDH deficient GIST, and that's Dr. Blakely and Dr. Hernandez. And then really importantly, trying to develop preclinical models of SDH deficient GIST. That's kind of held up our ability to really advance the field as much as we would like. Early on in the GIST clinic, from work here and work at other places, it was realized that in patients that had wild type GIST or GIST that didn't have a KIT or PDGFR alpha mutation, most of those GIST were driven by abnormalities in one of the succinate dehydrogenase genes. And here's a kind of a famous figure, at least famous at the GIST clinic, looking at the first batch of people who came to the GIST clinic and identifying mutations in one of the succinate dehydrogenase subunits in these patients. And that really helped advance our understanding of GIST. And many of the people that you saw in that picture a couple of slides ago played a major role in this research. One of the things I'm really excited about now, and this is work in Leno Tessarella's lab in one of the mouse modeling cores, is trying to develop a good preclinical model of SDH deficient GIST. This is a really interesting model that is kind of underway, and what Lino and Francesco were able to do was target gene knockout of succinate dehydrogenase specifically to the interstitial cells of Cajal. These are like pacemaker cells in the muscle of the stomach that are thought to be the progenitor cells, or the cells that SDH deficient GIST and really all GIST come from. So this is a nice picture here. This red is just a photomicrograph of the muscle cells in the stomach, and these green cells are staining for KIT, which is a marker of the interstitial cells of Cajal, as well as a marker of SDH of all GIST. And so you can tell that they've targeted the expression of this green colored gene to the interstitial cells of Cajal within the muscular layer of the stomach in a mouse. And if you make some gene mutations, and in this case it's a mutation that activates a pathway called BRAF, in addition to completely knocking out SDHB in these cells, the mice develop small tumors that look like GIST, and we're working on characterizing those now, but it's very exciting that we might have a murine model that we can really use to study therapies before we bring them into the clinic. From kind of developing from the initial SDH-GIST clinic or wild type GIST clinic, there are many people at the NCI who are interested in very rare tumors, and we've kind of expanded our efforts in the pediatric oncology branch to include a large clinical trial that looks at a number of different very rare tumors. One of the tumors that we really concentrate on is sdh-deficient GIST. And so we're interested in trying to develop a better understanding of very rare tumors, solid tumors in kids and young adults up to age 39. And this is called, the name of the study is called MyPart. And let's see, the people who have started the trial and are running the trial are Dr. Wedekin and Dr. Del Rivero. And so in this study, we try to collect patient information, tumor samples, medical records, and try to understand the natural history of some of these very rare tumors. We can help patients by providing some genetic counseling and some evaluation of family members where that's appropriate. And other investigators with particular interests in one of these rare tumors kind of take over the study of a particular subset of tumors. And at this point, you can see that wild type GIST, these are the number of patients that have been enrolled in the study since it was started a couple of years ago. And you can see wild type GIST is one of the most studied tumors and one of the tumors we have the biggest interest in. So thanks to all the people that have enrolled in the study, this is really important for us to understand how different subsets of GIST are different and really get a sense of the long-term history of natural history of people with SDH-deficient GIST. This is just a tiny bit of data that we've begun to extract. Over the last about year and a half, we've started to go back and try to recontact people who came to the very early GIST clinic before I got to the NIH. I think it's 12 or 13 years ago now, Sarah. I don't remember exactly when the first one was. And there's a talented pediatric oncology fellow who's working on this, Dr. Dagalakis. There's her picture up there. And this is just a brief summary of the first 61 patients that we've really gotten records from and really started to analyze. And the couple of things I wanted to point out about this, one is we have a variety of different subunit mutations in the patients that have been enrolled in the study. And the other is kind of a little bit of a cautionary tale. I think if you look at the population of patients that Dr. Sicklick sees and Dr. Bulusu sees, and we see here at the NIH, they'll be slightly different. And because it's a pediatric oncology branch, our patients are sort of skewed toward younger patients, and we have sort of a larger number of SDHC epimutant patients. Those patients are typically younger than you might expect in another center. So I think that makes this our specific group of patients very interesting, but also makes it interesting for us to compare with patients that are seen primarily at another center like Dr. Bulusu's or Dr. Sicklick's. This is Dr. Blakely's work. Dr. Blakely is a very talented surgeon who works here at the NCI and is interested in how different surgical approaches may impact people with SDH-deficient GIST. And this is just the beginning of looking at data as to what percentage of patients get one surgery, two surgeries, or multiple surgeries. And we're trying to understand how that impacts their quality of life and how people do over a longer period of time. And what factors may predispose a patient to requiring or getting more surgeries. And this is just stratifying the patients to those diagnosed less than 20 years of age and more than 20 years of age. And I think we have a lot of data that we are still sorting through that hopefully will give us some ideas about when, where, and how to do local therapy in these patients to help them do the best that they can. This is just a brief review of trials that have been completed in SDH-deficient GIST, which is actually kind of amazing. When people first started to study SDH-deficient GIST, it was very difficult to get a trial going. People didn't recognize the disease easily. It's a pretty rare disease, so it's hard to get enough patients on study to look at the trial. So in the US, the completed trials are Vendatinib, Guadocytabine, Lincitinib, 3 agents that had good scientific rationale behind them, but unfortunately none of the 3 really led to large responses. And this is just a list of patients who were on the Guadocytabine trial, which was run here at the NCI. this was under my list of ongoing trials, but I think enrollment has recently been completed. This is a really exciting trial of regorafenib in patients with sarcoma and sdh-deficient GIST. The overall primary investigator of the trial is Dr. George, Dana Farble, and then Dr. Chen and Dr. O'Sullivan-Coyne ran the trial at the NCI, and they just completed enrollment, which is exciting, and hopefully we'll be getting data from this trial soon. There are other really exciting trials out there. There's a trial of temozolomide, and Dr. Sicklick will talk about that. And there are other things coming down the line. So I think even just the ability to generate enough information to develop a rational trial, and also to be able to complete that trial is an important accomplishment in sdh-deficient GIST, and speaks to the dedication of the patients in finding these trials and enrolling on them and putting up with us seeing them many, many times during the course of the trial, and investigators developing and completing these studies. So what's next? I think there's a lot of momentum and a lot of things going on that may impact the ability to take care of people with sdh-deficient GIST in the future. I'm really hopeful that we'll be able to develop some better biomarkers in the future. Right now, we don't really have a great way of screening people who have germline mutations in SDH, one of the SDH subunits, for the development of GIST. And I think developing methods for this will be important. I think really understanding the role of surgery and other local therapies is a developing field, and I think that is really interesting. And hopefully we'll be able to get better and better at that in the future. I think there are a couple of preclinical models that are that have just come out, and we're just starting to understand how to use, and that will really help us to design studies that make more sense scientifically and hopefully have a better chance of being effective. And I think we still have a lot to learn about the natural history of the disease. You know, there are patients with SDH-deficient GIST that go for years and years, and the tumors don't change a lot, and there are patients that develop more rapidly progressive disease, and I don't think we have a clear understanding of why these subsets of patients are different, and knowing that, I think, would really help us take care of people. That's it. I hope I didn't go too long. Thank you very much. That's a picture of the pediatric oncology branch. And every year we make a gingerbread house for Christmas, and all of the pediatric oncology branch kids come in. So there are many faculty with many, many little kids. My kids are old now, so they come and help. There's Sophie. That one's my daughter right there. Anyway, thanks very much. Happy to take some questions.
Hi, everyone. I'm Ramesh Bulusu from Cambridge, United Kingdom. And what I'm going to do today is share our experiences in the post-GIST clinic in Cambridge. And thanks to Sarah for inviting us to this very important meeting. And meeting John and Jason is great because we share the same views and we have the same passion, and also we share the research ideas as well. So this is my disclosure. I just want to take you back to one quick slide before we go on to the post-GIST. GIST is a very heterogeneous disease. That's one thing we need to understand. And if we go back 20 years ago, back in 2000, 2001, 2002, we thought GIST is one disease and that's it. Now we know that there are multiple genes involved, and the most common being the KIT, and then the PDGF alpha. Then we have other genes like BRAF and TRAC, etc., etc. And my focus is on the pediatric adolescent wild-type syndromic GISTs. And the most important subgroup is the sdh-deficient GIST. John has made my job easier by explaining what the background genetic pathogenesis is. GIST treated by sarcoma oncologists in this country, in UK, but some of the gastrointestinal oncologists also treat GIST. I'm a GI oncologist. I specifically treat GIST. I don't treat the sarcomas. The idea for a pediatric adolescent wild-type syndromic GIST was born in a pub, and that was back in 2011. And what is important is this was a patient and carer-led initiative. It came from the patients and the families that they wanted to have a centralized clinic for patients with this rare subtype of GIST. And we started raising money, and then we established the clinic in Cambridge in 2014. And these are the consortium members. And we have oncologists, we have endocrinologists, we have geneticists, we have histopathologists, and we have radiologists. and specialist nurses. And this is our website, post-GIST clinic website, and the patients, carers, and also the healthcare professionals can access information by logging onto the website and see what's going on with the clinic and also any information from the clinical trials, etc. What's good about the website is that patients can register online. They put their details in and name of the oncologist, surgeon, and where they were treated or where they have operation. And they submit the details. And this form comes to us at the post-GIST clinic. And we chase everything. If they are treated 200 miles away, 500 miles away, we access this information. And the advantage we have in the NHS is that every person has a identifiable NHS number. That means we can track patients across the country. So as long as we have the NHS number, we can track them. And it's all the information is downloaded onto Cambridge website. There's also a social part of the clinic. So we meet up the night before and we go to a pub or to a restaurant, we have a meal, and we meet up people as human beings. That's the most important thing, to highlight that we as researchers and clinicians, we're also human beings and we're part of the same journey, and we share our experiences, and the patients have opportunities to ask questions. And it makes them more comfortable when they come to the clinic next day, having seen us in kind of real life. So far, what we've done is that we had 24 clinics. We run 3 clinics per year, one in spring, one in summer, one in autumn/winter. We had about 116 patients. And as you can see, dominant is female 2:1 to males, and the much younger compared to your KIT mutant GISTs. Again, what is striking is the heterogeneity, meaning each one of these patients are very, very different. And other thing what we have learned is that if a patient comes into the clinic with a wild type GIST label on the tumor, we recheck because 7% of the patients who came into the clinic had a missed KIT or PDGFR5 mutations in their GIST, because a number of years ago the technology hasn't evolved much, and the older tests have missed some of the mutations, so we always recheck. This is the age distribution in the clinic. All comers, much younger, but what is striking in the sdh-deficient GIST is the second and third decade, and possibly up to fourth decades, is a striking age distribution, and it's very unusual to see sdh-deficient GIST over the age of 60, 65, 70. But we've seen them. And the molecular subtypes, big chunk of the patients, 50% are sdh-deficient coming to the clinic, and a smaller number NF1. We have the largest cohort in Europe for the NF1 patients in UK. So we have 30 patients so far. And quadruple negative is the other chunk. We are routinely sequencing now for NTRK. And also one of our pathologists has validated a NTRK immunohistochemistry. So we use that as a screening test to start with. And in the NHS, we have access to NGS and also whole genomic sequencing on the peripheral blood. As John has pointed out, the patients had emergency resections. This is striking compared to your adult KIT mutant GIST patients, much higher. And about 2% of the patients have been treated with at least one TKI. We have developed a program here in UK using selective internal radiotherapy for liver metastases, which I'll come to that in a minute. And we have not as yet had GIST specific trials, sdh-deficient GIST specific trials, but some patients have been to early phase 1, phase 2 trials. What we have learned in the last 10 years is imatinib probably doesn't work. I think we have to say that. Sometimes we see stable disease, but it may actually reflect the natural history of the disease rather than actually imatinib doing something. But we know anecdotally, some people say that imatinib has slowed the disease down. We certainly have seen some responses to sunitinib, but more so with regorafenib, and also with some objective responses and also symptomatic benefit. We think that regorafenib certainly has activity in this type of GIST. Predominantly female, younger age group, keloid morphology, often multifocal, and as John was saying, it could be germline SDH subunit mutation or the promoter hypermethylation. The SDHB immunohistochemistry is the first thing we do. Make sure that along with the KIT PDGF alpha mutational analysis, we routinely do SDHB immunohistochemistry as a screening procedure. The one thing we have to do is go back to the basics. That means we go back to our what you call high school, or we call it A levels, understand the Krebs citric acid cycle, and where the succinate is converted to fumarate, and in the absence of the succinate dehydrogenase enzyme, the succinate cannot be converted to fumarate, and that's where the problem starts. As John highlighted, this is the basic understanding, and if you don't understand this, it will be very difficult to develop any therapies for this type of GIST patients. This is a slide I borrowed from Dr. Mook's paper back in 2020. This summarizes where we want to focus. And one of the aspects is looking at the kinase inhibitors, that is regorafenib, etc., and also, as John pointed out, demethylating agents using decitabine and gordocytabine. Perhaps we have to go back to the drawing board and see whether there's a different way of delivering these drugs. And also looking at temozolomide. Jason has already got a lot of experience using temozolomide in the sdh-deficient GIST. Combining temozolomide with PARP inhibitors is an exciting concept. And also more recently, we started looking at targeting the HIF-alpha pathway as well. So this is the HIF-alpha pathway trial, which is hopefully opening soon in Cambridge. So looking at one of the cohorts is the sdh-deficient GIST patients, and this is going through the regulatory process right now, and we're not as yet recruiting. Ruth Casey, who's our consortium member, has initiated a trial looking at the radio-labeled gastrin-releasing peptide receptor therapy, and we have treated our first patient in Cambridge last month. And Michael Hendrick has also treated some patients in Oregon. So this is an exciting thing for us. We're hoping that there will be some results coming through in the next few months. Intervention called selective internal radiotherapy we have initiated in UK, and Jason has got some patients, and also Peter Hohenberger from Germany has got a patient. We have treated 4 patients so far, and the rationale is that sdh-deficient GIST have defects in DNA repair mechanisms, and one of the most efficient DNA damaging agent in the oncology is radiation. So if you actually can deliver enough radiation to the tumors, you can kill them because they cannot handle the DNA repair. And we discuss these patients in our tumor board meeting and make sure that they are suitable and there are standard inclusion-exclusion criteria, and they need to have a good, stable liver function. The procedure itself is in 2 steps. One is the feasibility and safety assessment with technetium, make sure that you want to get the radionuclide into the right place. It is not leaking into the lung or into the stomach or other parts of the GI tract. Once it is done, then patient comes back and they get the therapeutic dose of the yttrium delivered through the common hepatic artery, either into right lobe or left lobe or both lobes. So patient stays for 24 hours and then discharged on medication. This again is a pragmatic decision we made to put the patient on antiemetics and proton pump inhibitors and also short course of steroids to minimize the risk of any radiation-related hepatitis. They get the bloods done weekly for 4 weeks, and then we do the repeat imaging, usually MRI with contrast, around 10 to 12 weeks. I'll show you the second patient we have treated back in 2019. That was nearly 4 years ago. So the one here with I can see the arrow there. See, these are the multiple liver metastases, all the 4 arrows pointing. This is baseline pre-cert treatment. And this year, there's hardly any disease visible. So she has been in very good remission for nearly 42 months. And it's now 44 months now. So she has been off any treatment. She has not required any TKIs. This is the one treatment, one single dose of yttrium. And she's for the first patient we have treated was 54 months ago. She is still in ongoing remission. And the third patient, 21 months in remission, partial remission. And fourth patient was treated just about 2 weeks ago. This is our data set on the NF1 GISTs. And again, the striking is the female to male preponderance and different age group. The natural history is very variable. Some of them are very indolent. Some of them can be very aggressive. We don't know as yet the biology of this, what drives these tumors. It is not KIT, something else, NF1, some other things going on. And so far, we have treated about 7 patients with the conventional TKIs with no objective responses, and all died of progressive disease. As you all know, the only trial which was initiated actually was closed a long time ago with no recruitment. And this begs the question, we should be collaborating. That's my kind of a theme for the last 5-10 years. We need to collaborate. And this is where we need to engage with our colleagues. We're doing that already as part of the sdh-deficient GIST consortium. And also we need to engage with people elsewhere as well. So as part of that, we have applied to join the International Rare Cancer Initiative. And we submitted the application form about a couple of months ago. We should be hearing from the IRCI in the next couple of weeks. The trial we proposed is the temozolomide with a PARP inhibitor, and it's a drawing board stage, and it's a long way to go. So the other thing which is happening in UK is we are close to getting a final draft ready for the position paper from the post-GIST consortium. And this document, we hope, provides practical guidance for clinicians involved in the day-to-day management of post-GIST patients, and also provides a platform for future engagement with researchers, both in UK and elsewhere, to understand the biology and stimulate effective treatments. And this is the holy grail for us, all of us, to find effective treatments for this rare subtype of GIST. Clinicians is the key, working with patient advocacy groups, and we have to have the patients on board and the carers on board so that they can have a clear say in the development of clinical trials. It's not just me or John or Jason saying this, we got a drug we want to try. We want to make sure that we engage with the patients and the carers and have patient advocates sitting with us and say, this is what we want. And this is where I'm going to stop. And thank you to GIST Cancer UK, Cambridge University Hospital team, post-GIST administration team, Jane Bessington in particular, and also the patients and families and carers who made this possible, and the fundraisers. Thank you.
Thank you, Dr. Bulusu. I think what you've heard from both Drs. Glod and Bulusu is that collaboration is very important when researchers and clinicians want to do more for the patients. It's important to work with the patients and the advocacy groups to make that happen. So it's been wonderful to see the output from the clinics and what more is down the pike. And so I would like to now transition to Dr. Sicklick, who will discuss his research.
Good morning, good afternoon, and good evening. I think we've got people from all over the world. I can see from South America, North America, and Europe, UK. Can you see my screen okay?
Yes.
Okay, perfect. Well, thank you again, Sarah, for the invitation to speak today. I'm going to talk a little bit about the work specifically that we're doing with the succinate dehydrogenase deficient GIST and new ways to think about targeting these tumors. And as you can sort of see, for many years, the discussion around GIST has really focused around KIT. But what we've learned over the years is that the story goes beyond KIT. You heard about the PDGFR alpha mutant GIST. You've heard about the NF1 mutant GIST and BRAF and the gene fusion GISTs, as well as the succinate dehydrogenase deficient or SDH deficient GIST. And even within the GI tract, there's actually specificity to where these tumors tend to occur. It's interesting that the gastric location or the stomach is the only location where these SDH deficient GIST tend to occur. And interestingly, they tend to occur only in the bottom part of the stomach, as you can sort of see there in the gray parts of the pie charts. And it's this subset of GIST patients that I'm going to focus in more today, sort of moving from, you've heard about the work that's been done in the PAUSE clinic, as well as the NIH clinic, sort of trying to understand and getting us kind of to the point where we can separate these as a patient population from the KIT mutant GISTs. And now, how do we think about, new ways to target these tumors? And so just a little bit of background reminders. You've heard some of this already, and I'll just add on a few points. So roughly about 10% of all GISTs are the SDH deficient subtype. These are a little bit unique from some of the other types of GIST because not only can they spread through blood and then within the abdominal or peritoneal cavity, but they also are unique in that they can spread through the lymphatics and go to lymph nodes, which is different from all the other types of GIST, with the exception of the gene fusion GIST, which are the NTRK GIST that Dr. Bulusu mentioned before, as well as FGFR fusion GISTs. The SDH deficient GIST really come in sort of two flavors, as you've heard, the Carney-Sirtakis or syndrome type, which are the mutations that are carried from parent to child. And so these are, multiple generations affected, and these patients can also get the paragangliomas. And then the Carney's triad, or the SDH epimutant patients, which are sporadic. We don't know exactly why. It only occurs in generally teenage girls, and that's that population that Dr. Glod was sort of alluding to, of the pediatric population that tends to be enriched in their data set from the NIH. And these patients also tend to get pulmonary chondromas, which are benign, meaning non-cancerous tumors in their lungs. This is data actually combining the work that Dr. Glod, Dr. Blakely, and I have combined data from UC San Diego as well as the NIH, looking at survival of patients with SDH deficient GIST. And for many years, people talked about SDH deficient GIST as being an indolent disease, meaning a slow-growing tumor where very few patients passed away from their disease, and so that if somebody was diagnosed with it, we didn't have to worry about it. But when we actually looked at our data, which you can see here, this is called a Kaplan-Meier curve. This is a survival curve, where what we see is about 20% of patients with SDH deficient GIST passed away in the first 6 years. And once we get beyond that sort of 6-year point, you can see there the curve becomes significantly flatter, and that we're seeing much fewer patients passing away from their disease. So it's really this kind of population of patients that are passing away early on, that have much more aggressive disease than we've previously appreciated. That's been the focus of our work and my laboratory's studies. Now, there's lots of drugs that are FDA approved for GIST. There's the imatinib in the first line, sunitinib in the second line, regorafenib in the third line, and now ripretinib in the fourth line. And these all target KIT. But the problem is that these drugs, with the exception of regorafenib, don't work all that well for the SDH deficient GISTs. And what you can see here in this table is data from all the prospective clinical trials looking at CRs, or complete responses, meaning the tumors completely disappeared. Partial responses means that there was a greater than 30% shrinkage of a tumor. And the ORR is the objective response rate, meaning the combination of complete responses and partial responses. And so what you can see here is that with the sort of standard first through fourth line FDA approved drugs for GIST, if we were just to take any patient that comes in the door and didn't do all the appropriate testing to look for SDH mutations or expression of SDH, we wouldn't see great results with most of these drugs. And unfortunately, there was several well-designed trials that were started to look at different targets that were identified in these SDH deficient tumors. And Dr. Glod alluded to the three drugs that targeted these, lincitinib, vandetanib, and guadocitabine. And unfortunately, in all three of these trials, we didn't see any responses to therapy. And so, that leaves us in a situation where we're still, searching for better drugs to treat these patients. And as Dr. Glod mentioned before, one of the major challenges to advancing the SDH deficient GIST field was a lack of preclinical models, meaning models that we could study in the laboratory. And so several years ago, my laboratory set out to sort of tackle this. And as a surgeon, obviously, I'm operating on these patients. I'm getting access to tissue when I remove their tumors. And so we used those tumors, we sent them back over to my laboratory. And then with a little bit of luck and persistence, we were able to develop the first patient-derived SDH GIST cell models that we were then able to analyze and test and compare to make sure that they replicated what the tumors that they were derived from looked like. And it turns out we were able to do that with three different tumors that I removed in the operating room. We were able to do this with an SDH-A mutant tumor, an SDH-B mutant tumor, and an SDH-C mutant tumor. And what you can see here, these are cell viability curves where basically there's increasing drug concentrations on the x-axis, and on the y-axis, this is the percent of cells still alive in a petri dish. And what you can see here is that the deeper the drop off will be, that means that the cells are dying off. But if they're sort of flat, like you can see here with imatinib on the left side, that tells us, with the exception at the very, very high doses of imatinib, it's not working very well. If you look on the right here, this is sunitinib, and you can see here, until we get to the higher doses of sunitinib, we're not seeing much cell killing. All the cells are, generally surviving. But it turns out that there are other potential vulnerabilities in SDH deficient GIST. And if we go back to 2003 and 2005, there was actually two studies done looking at a drug called temozolomide, which is a DNA damaging agent or a DNA alkylating agent that basically messes up the DNA in cells. And this is now FDA approved drug for brain tumors. But there was actually two studies performed in the early 2000s, each with 18 patients, looking at patients with GIST. These were unselected patients, meaning any patient with GIST. And so statistically, you'd figure most of these were KIT mutant GIST. And unfortunately, they did not see a single response, again, in either one of these trials. But in 2017, there was actually a study done looking at patients with paraganglioma, that sort of sister tumor that occurs in these SDH deficient patients. And what you'll see here is on the lower part of this table is that patients that had normal SDH-B expression and didn't have mutations did not respond to therapy. However, 50% of the patients with SDH-B mutations responded to therapy. And so this sort of gave us a hint that this may be, a targeted therapy for these patients with SDH deficient GIST. So we actually went and looked at our cell models. And what you can see here is that we can start seeing increasing cell killing of our SDH deficient cell models with temozolomide. Furthermore, this is work in collaboration with Mike Heinrich's lab up at Oregon Health Sciences University. And what his lab developed is this cell line that basically has either wild type or normal expression of SDHA, knockout of SDHA, meaning they completely got rid of SDHA in the cells, or knockout, meaning they got rid of it, but then they gave it back as sort of a rescue of the gene. And what you can see there on the left side, as well as on the right side on the actual plate itself, is that when the cells are treated with temozolomide, when they have normal wild type expression of the SDH gene, they're resistant to temozolomide. But when you get rid of the SDH gene, they become exquisitely sensitive to temozolomide. And so we went back and looked at our cell lines, and basically what we showed was that the temozolomide drug is inducing the effects on the DNA that we would expect based on what we call a COMET assay, as well as staining for different markers that are markers of DNA damage here. And so suggesting that this was an on-target, meaning that the drug was doing what it's supposed to do in terms of affecting the cells. And so what ultimately this led to back in 2019 is development of a phase 2 study of temozolomide in patients with SDH-deficient GIST. This was the trial was led by my colleague and collaborator Adam Burgoyne, who's one of the medical oncologists here. And so we initially, with a small amount of pilot funding from a Pedal the Cause grant at UC San Diego, we got this trial started in San Diego, and then went on to get additional funding from the FDA as well as from the Phase 1 Foundation to then open the trial up at 3 other sites around the United States. Oregon Health Sciences University, led by Dr. Heinrich, Fox Chase Cancer Center, led by Dr. Von Marin, and the University of Miami Sylvester Cancer Center, led by Dr. Trent. And it was really with this collaboration that we were then able to run this trial. Now, I'm only going to show you some sort of interim analyses, meaning that this is not the final data. This hasn't been released yet, but this was our interim analysis in December of 2021. This was basically at a time point when there's a rule within the trial that when we get to a certain number of patients, we got to make sure that the drug's actually being effective. Otherwise, we stop the trial. And so when we hit our first 9 patients, we asked the question is the drug working? And so our primary endpoint was looking at responses or partial responses, meaning greater than 30% shrinkage at 6 months. And it turned out actually 2 out of the 9 first patients that we treated, so 22% of the patients had prolonged responses to therapy beyond 6 months. So this basically, the trial passed our interim futility analysis. And so we went on to then continue enrolling patients on the trial. During the trial, we also, during this time, we also were able to take several of these patients to the operating room, given that they had responses to therapy or stabilization of their disease when it was progressing. And ultimately, we've now gone on to complete the trial and treat 23 patients on the trial, representing one of the largest SDH-deficient GIST trials performed to date. We've submitted this data for presentation at the CTOS meeting later this year in Dublin, Ireland, and we're pulling together the final analyses now for publication. So in summary of where I've talked about already, we've developed an SDH clinical and research program at UC San Diego that's allowed us to develop the first approach for generating human SDH deficient cell lines that we can then begin to study in the laboratory, and which allowed us to really kind of determine that temozolomide may be a therapy that we can use for these patients with SDH deficient GIST. Moving our discoveries in the laboratory back to the clinic, we were then able to open up a clinical trial of temozolomide and treated 23 patients with this type of GIST. And we see a promising signal as a potentially new therapy for SDH deficient GIST patients. But unfortunately, not all the patients are responding to single agent temozolomide. And so one of the things that we know is that there is crosstalk between the DNA damage response and what's called endoplasmic reticular stress. And so the endoplasmic reticulum is basically part of the machinery in our cells that sort of helps in the assembly of proteins. And so what's known to occur is that when temozolomide causes DNA damage to cells, this also sort of activates this ER stress, this endoplasmic reticular stress, that then causes misfolding of proteins, and then activation of sort of a signaling pathway through which there's activation of proteins called E2IF alpha, which then leads to expression of other genes, including this gene called DR5, which then is on the surface of a cell. And DR5 is also known as the death receptor 5 because when it gets activated by a molecule or its ligand, meaning that this sort of trail ligand comes in, that actually turns on the DR5 pathway, which then leads to what's called apoptosis or programmed cell death. And so ultimately representing a different pathway that could be theoretically targeted. And so it turns out when we treat the cell lines with temozolomide, we see upregulation of components of this pathway, including increased expression is based on these markers, these lines here of protein of that DR5. Furthermore, if we look at 3 of the patients treated on the temozolomide trial, these are tumor biopsies from tumors that I resected in patients following treatment on the clinical trial. What you see here in brown is that these tumors have the DR5 protein following treatment with temozolomide. We then went back to our cell culture models and asked the question is, if we give the recombinant trail ligand, that activator of DR5, can we affect the cells? And so what we did here with the SDH-A and the SDH-C lines is we gave the trail ligand back here in blue. And unfortunately, without just alone, we don't see much of effect with trail ligand. But when we give it in combination with temozolomide here on the far right bars, we see a decreasing cell viability relative to the controls or even relative to the temozolomide alone. But what's exciting is actually in San Diego, there's about 200 or so biotech companies in the local area in San Diego. And one of them is called Inhibrx, and it's actually a spin-off company from UC San Diego. And they've got one of 2 drugs in the world right now that targets DR5 or that death receptor 5. And that drug is called Inhibrx 109. And basically what it does here in green is it binds to the death receptor 5, which then leads to activation of this cell killing pathway. And what's unique about the Inhibrx 109 compared to that trail that I mentioned to you before is trail doesn't work as well at bringing together the components of this receptor. It only brings together 3 of these DR5 receptors together, versus this Inhibrx 109 can actually bring 4 of them together, which dramatically increases the cell's ability to signal through this pathway and cause cell killing. So it turns out that this Inhibrx 109 is about 50 to 100 times more potent in the laboratory than the early generations of drugs that targeted DR5 as well as trail. And so really sort of now leading the way as being potentially a new and really great opportunity to target these patients' tumors. And so we went back to our laboratory work, and basically what we showed here, these are looking at proliferation of cells, and what you see here compared to the controls at 100% is that we have dramatically decreased cell proliferation when we give the combination of temozolomide and Inhibrx 109, and we see increasing apoptosis by about 7-fold, and we see increasing cell death as well. And this is just some additional images. You can see here the combination, the increasing number of green cells here on the bottom, as compared to the controls or any single agents alone. So again, this combination suggests that it may be an efficacious combination. We then looked at actually, are these additive or synergistic? Additive meaning 1 + 1 = 2, and synergistic meaning 1 + 1 = 3, or 1 + 1 might even equal 4. And what it turns out is that synergy, we can actually look at the synergy scores for given the combination. And it turns out that this combination of giving temozolomide plus Inhibrx 109 is not just additive of the effects, but synergistic, meaning that they're working together to the sum is greater than the parts. And so what this has led to is Inhibrx is now initiated a phase 1 trial of the combination of Inhibrx 109 plus temozolomide. A trial is now open at 15 sites across the United States. We opened it in September of last year. The trial is a phase 1 trial, which means we're doing a dose finding trial using the dose of temozolomide that we used in the first study, and now looking to find a safe dose that we can give in combination with the temozolomide for the Inhibrx 109. The trial is not only open to sdh-deficient GIST patients, but they're given all the findings that I just showed you. There's potential that this may not just only work in GIST, but in paraganglioma, as well as paraganglioma's sort of sister disease, pheochromocytoma, as well as renal cell carcinoma or kidney cancer. And so this trial is now open to enrollment. As I said, it's open at 15 sites around the United States. The first patient has already been treated and is undergoing imaging later this month. There's a couple other patients that are in the queue to be enrolled, and several other patients that are being evaluated for potential enrollment on this trial. And where do we go next? Well, we've actually now developed a consortium of collaborators across the United States working with Dr. Glod, as well as you can see here, institutions across the US and with the support of LifeRaft, all of us working together to create a consortium to now actually plan the next step, or the phase 2 trial for the combination of these drugs once we've developed the final dose. And with that, I want to say thank you to all of our groups that have funded us, and specifically to all the funding we've had for our sdh-deficient GIST research, including the FDA, the Phase 1 Foundation, the SDH Research Advocates, the Lighting the Path Forward, Pedal the Cause, and Miles for Merrick, and last but not least, the LifeRaft group. And this is all work done by many people and many collaborators. I want to give credit to all the folks in my laboratory there, as well as collaborators at UCSD and the other institutions, including Dr. Glod and Dr. Blakely at the NCI. And with that, I will stop and happy to answer questions. Thank you.
Okay, amazing. Thank you so much, Dr. Sicklick. To do it. So there were some questions that came into the chat. So I'm just going to get started with those. So when you were talking about complete response, ORR and whatnot, there was a question that came in. If the tumor shrinks by 1 centimeter, is it a partial response or complete response for a tumor size that's 7 centimeters? And this patient is a KIT mutant patient who's currently on Sudan.
So, doing the math quickly on the top of my head, 1 divided by, 1 out of 7 is going to be somewhere around a 15% or so, or 14.5% response to therapy. So that would not be considered a partial response. To get to a partial response, you'd have to have a greater than 30%. So, doing the math in my head, probably at least a 2.5 centimeter shrinkage, from a 7 centimeter tumor. And to be a complete response, that would mean a 7 centimeter complete disappearance of the tumor.
Okay, thank you. If anti-angiogenic drugs such as regorafenib, help, can an anti-angiogenic diet help? And there was also a follow-up about, if SDH deficient GIST has an overexpression of IGF-1 and intermittent fasting results in lower levels of IGF-1, why doesn't intermittent fasting help? Is there a possible link?
Deep breath.
Ramesh, you wanna start with this one?
I mean, I think what we have to be very clear is that we still do not understand the biology that well, the link between insulin growth factor receptor and the SDH, and we do not know whether there is a driver, IGF-1 related driver, which will actually do anything to the SDH deficient GIST. So, I mean, I do not recommend this intermittent fasting to my patients. I think we need to learn more about these tumors before we get into these kind of discussions. Also, going back to the previous question about the objective responses, meaning the tumor shrinkage, I personally am not unduly concerned about what happens to the tumor size-wise, especially with a KIT mutant or a PDGFR mutant GIST. If the disease is stable, patient is well, we carry on with the treatment. We don't get disappointed that tumor has not shrunk. I think stable disease is as good as having a shrinkage. We need to get that message across to our patients. We should not be really obsessed with size that much.
Okay, so there's also a patient with exon 11, a young man, 38 years old, who's failed the first 3 lines of therapy, can't get access to Kinlock. Unfortunately, this is a story that we hear too often. So just want to know, for those, this is somebody based in the Netherlands, so maybe this is for you, Dr. Bulusu, you know, what kind of questions can you ask his doctor regarding other options when you can't get access to the 4th-line treatment of ripretinib?
We have the similar situation
and
in
there's
the
a
UK.
follow-up question about should you debulk? So based in Netherlands.
Yes, I think the one thing we have learned from the big American studies, MD Anderson, Sloan Kettering, and also Jason Teta, is that debulking surgery in the 3rd, 4th line setting is of not much of a survival benefit. We do it for reasons where there is a patient has symptomatic either bleeding or painful metastases. We do not routinely recommend debulking, at least in this country, in the 3rd, 4th line setting. Right now, we are in the same boat as the Dutch. We do not have access to ripretinib in UK. The NICE has said no to it. We may revisit this in the future. What would be useful for this patient is to talk to, because Dutch team oncologists are very, very active in clinical trials. Depending on where he is, you should be accessing either Amsterdam or Rotterdam to, or even go to Belgium to see Strosky, see whether we can access one of the newer trials, which is opening very soon. It's the TO630 trial, which is a pan-KIT inhibitor, which might be an option for this patient.